First, we must consider the different neuropathic pain types. Neuropathic pain can be diverse in nature, encompassing a wide range of pain types, including post-herpetic neuralgia, painful diabetic peripheral neuropathy, and painful cancer-related neuropathies. Gabapentin has been shown to be beneficial in treating several types of neuropathic pain. However, the mechanism of action by which gabapentin exerts its analgesic effect is still unknown. It is suggested that gabapentin may block the calcium channel alpha-delta receptor in the brain. This protein-modulated receptor is involved in excitatory synapse formation. Therefore, the therapeutic effects of gabapentin may be attributed to prevention of new synapse formations. Gabapentin was shown to offer substantial improvement in neuropathic pain with side effects that were similar to those on placebo. Even with sufficient data supporting the use of gabapentin in the treatment of various neuropathic pain conditions, gabapentin only has Food and Drug Administration approval for PHN. Dosing recommendations for off-label use of gabapentin can be somewhat ambiguous, if a recommendation exists at all. Therefore, several studies further investigate dosing regimens specific to other neuropathic pain syndromes. Gabapentin dosing considerations. 3 gabapentin products are FDA approved to treat PHN. The different formulations cannot be interchanged and each has its own dosing schedule. For immediate release gabapentin, dosing may be initiated with 300 mg on day 1, doubled on day 2, and tripled on day 3. The dose can then be titrated up as needed for pain relief to a maximum dose of 1,800 mg daily. Clinical studies referenced in the package insert state that efficacy for a range of doses from 1,800 mg/day to 3,600 mg/day were observed. However, there was no additional benefit seen with doses greater than 1,800 mg/day. Crolize is an extended-release gabapentin formulation that also is FDA approved for PHN with a titration schedule that begins with 300 mg on day 1, 600 mg on day 2, 900 mg on days 3 to 6, 1,200 mg on days 7 to 10, 1,500 mg on days 11 to 14, and 1,800 mg on day 15 and thereafter. The third gabapentin formulation for PHN treatment is another extended-release product, Horizant. The starting dose is 600 mg in the morning for 3 days, increased to 600 mg twice daily on day 4 and thereafter. A daily dose of Horizant greater than 1,200 mg provided no additional benefit at the expense of side effects. Several studies have evaluated off-label use of gabapentin in the treatment of other neuropathic pain conditions. A randomized, double-blind trial compared gabapentin to placebo in 135 patients with DPN over 8 weeks. The results showed a statistical benefit of gabapentin compared to placebo, at all endpoints. For pain improvement, point for the gabapentin dosing regimen used in this study was 900 mg/day for week 1, 1,800 mg/day for week 2, 2,400 mg/day for week 3, and 3,600 mg/day for week 4. All the patients were titrated up to a dose of 3,600 mg/day, regardless of efficacy at lower doses. Patients who could not tolerate this dose were titrated down to the greatest tolerable dose. Of the 84 patients randomized to the gabapentin group, 56 were able to tolerate 3,600 mg/day. During the first week, gabapentin resulted in improvement in sleep interference compared to placebo. By the second week, gabapentin resulted in improvement in all pain rating scales compared to placebo. Of the 84 patients in the gabapentin group, 70 completed the study, and 7 patients withdrew due to adverse drug events. Most AIDs reported in the gabapentin group were of mild or moderate intensity, and the most frequently reported effects were dizziness, somnolence, headache, diarrhea, confusion, and nausea. A double-blind crossover study assessed gabapentin for the treatment of DPN. The dose of gabapentin used in this trial was much lower, with patients titrated up every 3 days to a maximum dose of 900 mg/d. The endpoints evaluated in this study included level of pain on a visual analog pain scale, and scores on the Present Pain Intensity Scale, the McGill Pain Questionnaire, and the Global Assessment of Pain Relief. Statistical improvement between gabapentin and placebo was noted in only one endpoint, the MPQ score, with a mean reduction of 8.9 points for gabapentin compared to 2.2 points with placebo. No serious AIDs were noted, and the most common AIDs of gabapentin were drowsiness, fatigue, and imbalance. The results of this study suggest that gabapentin is not effective or is only minimally effective in treating painful DPN at a dose of 900 mg/d.